All right, thank you. Sort of surprised to see a number of people leave as you introduced me. They're going to miss out. Okay, so my name is John Mascarenhas. I've come to this conference many times. I really enjoy this aspect. We give a lot of talks to other physicians. I think it's really meaningful and important for us to talk to patients. So I actually think that, and I think my colleagues would agree, we learn a lot, as physicians, we learn a lot from interacting with patients and sort of understanding how you're interpreting what we're doing and whether we're both on the same page. What I'm going to hope to do is go through myelofibrosis, and I actually think this is relevant to everyone in the room, whether you identify as ET, PV, myelofibrosis, or something else, because there is a fear, obviously, that one could progress to myelofibrosis. And just so I understand my audience, if you could just raise your hand if you feel comfortable. Raise your hand if you're here because you have myelofibrosis or you're here for someone with myelofibrosis, just so I have a sense. Okay. And then raise your hand if you're worried about getting myelofibrosis. So it's everyone. Yeah, that's what I thought. So I think this is really going to be pertinent to everybody. Do I use this, or is it the mouse? The mouse. Okay. So what you'll notice, and first of all, thank you. I'm looking at Trent specifically. Thank you for coordinating this meeting, and for Ruben, Jean, and everyone else for inviting me and putting this together. It really is excellent. What you'll notice is that in this talk, I will have a red. I'm going to overwhelm you with this talk. I realize that. So what I'm going to do is I'm going to have a red circle or oval around where I think the key part in each slide is. So if you focus on the red oval, for the most part, I think you'll follow where I'm going with this. What you'll notice is I will not be, not that anyone else did, but I won't be talking down to you. I'll be showing you slides that we show at meetings. So it really will be the data and the slides that we use when we're talking to each other. But I'm going to try to give it in a way that it will hopefully be meaningful to you. And those red circles will draw your attention to where I think it's important. So new. So these are new drugs in MF. We're going to talk about new JAK inhibitors, new non-JAK inhibitors, and then JAK inhibitor-based combinations. So everything somehow relates to JAK inhibitors, well, whether it's directly or indirectly. So the new JAK inhibitors, these are the new kids on the block that we're going to talk about, and they don't have names yet. When they're too early on, they don't really have a catchy name. So they're just letters and numbers. So INCB 160058, this is a selective JAK2 V617F inhibitor, and then AJ 11095, this is a type 2 JAK2 inhibitor. So again, keep your eye on that red circle, because that's really the meaningful point. So the whole point here is that we have 4 very excellent, very helpful, and some of you may be on them, approved JAK inhibitors. They're all type 1 JAK inhibitors. They all work in a very specific way, and they're all rational in their design, but they're not specific for the mutant form of the protein, and they don't selectively inhibit or delete the cell population that we're trying to go after. So they bring a lot of good. They reduce spleen symptoms. They improve people's health. I do think that they improve survival, but they do not remit the disease. So really, the next couple slides, what you're going to see is a different angle on a similar theme. Can we target JAK2 more effectively with a different approach to shut down the signaling pathway and ideally change the clonal dynamics of the disease and get even better results than what we've seen so far with the type 1 JAK inhibitor. So the first one we're going to talk about is this drug, INCB 10058. This is an insight drug. And what I'm going to show you here, I think you'll appreciate. Remember, always look at those red circles, because that's where the money is. So what I'm going to show you here is what leads to us even doing these trials. This is an early phase 1 study, first in human. But before we do that, we have to prove that there's rationale, that this makes sense in cells from patients, cell lines that mimic patients, and then animals that are engineered to have this disease. What I'm showing you here is some cell line work. And what it's showing is that if you look at ruxolitinib on the left and then the new drug on the right, you'll appreciate there's a divergence in the curves. And what it shows is that if you have JAK2 wild-type cells versus mutant cells, there's really no difference in the cell viability with Jakafi. It kills both types of cells to the same degree in a dose-dependent fashion. But on the right, you see a separation in the curves. Why? Because this new drug is selective and more potent for killing V617F mutant cells than wild-type cells. So that's why you see those curves disappear. That makes all the difference. Because if you can selectively target the mutant clone and leave and spare the normal guys, then you might have more of a chance at a potent dose of really making a difference in this disease and taking this approach of JAK inhibition to the next level. And that's what this study is hoping to do. And I hope all of these studies accomplish this. And I have no idea which is going to be the best, but I love the fact that we have multiple to choose from. This is one example of the next generation of JAK inhibitors. 4 type 1 JAK inhibitors improved. Here we're looking at a JAK2 V617F selective inhibitor. This one is going to go after the JAK2 in a different way. It binds in a different way. It changes the conformation of the protein. And it will ultimately, if it works as it does in the lab, it will ultimately be more selective for the mutant form of the protein. Again, look at the red circle. So it's only for patients who are JAK2 mutants. So if you're in the audience, you say, well, damn, I'm not JAK2 mutant, so this is not going to be very relevant to me. Hold on, I got more for you. But this is for JAK2 mutant patients. We're going to dose up. So you start low and you titrate up the dose. You look for safety, and then you look for what looks like a good ratio of activity in the patient, spleen reduction, symptom improvement, reduction in JAK2 V617F, VAF. We've heard it a million times, VAF, variant allele fraction. Can we reduce that amount as a surrogate for the amount of burden of disease in the bone marrow, in your body? So this is the first step of trying to understand. This is a phase 1 study. Can we do better than the type 1 JAK inhibitors that we have available to us? As a high bar, but I think we can do it. Second one, AJ11095. This is a type 2 inhibitor. I keep saying all the other ones are type 1 inhibitors. They bind in a very specific way to the JAK2 enzyme to stop its activity and the downstream signaling pathways that are exerted. And what's perfect about today is everyone built up so that I think there's somewhat of an understanding of the audience of the biology that's been laid out beautifully by my co-faculty here. And what this drug is going to do is it's going to bind in a different region of the protein, change the way that protein is again behaving, and its ability to dimerize and then activate that signaling pathway through the receptor. So what this is doing is saying we're going to bind differently, and we don't care if the protein that we're binding is active or inactive. We're going to shut those JAK2 proteins down. In models, this looks very, very effective. In models. So before it gets to the human, very effective. We're going to find out if it's going to be effective in humans, because that's the point of a phase 1 study. Is it safe? And then can we actually see the same kind of results that would lead us to believe that we should move this into later stages of testing? So that's AJ11095. And you'll see I'm going through these pretty quickly because there's no data on these yet. I'm just showing you what's out there and what's new with JAK2 inhibitors. What about non-JAK2 inhibitors? So we have 3 drugs that I'm going to highlight. And if you're on a drug that's not listed here, that doesn't mean I don't think it's an important drug. I'm just picking some of the drugs that are the furthest along that I can talk about with a lot of excitement. But there are many other drugs that might fit the bill here that might be a great topic for a future meeting. But the ones I'm going to highlight are nuvisertib, a PIM1 kinase inhibitor, reparexin, a CXCR1/2 antagonist, and then this other drug, which is 33989. You'll notice INCs that bear again because it's an Incyte compound. And this is the mutant CALR antibody that we've already had a little appetizer of in a previous talk. So let's first talk about nuvisertib. Nuvisertib, otherwise known as TP3654, it's a PIM1 kinase inhibitor. You don't really need to know what that means, other than it is another enzyme that is important in cell signaling. And you caught that. Did you just point out that I don't have the red circle? You did. God damn it. You guys are paying attention. That's great. I don't, but not on this slide. That's fantastic. You just made my day, sir. I'm a little disappointed, but you made my day. So nuvisertib it's an inhibitor of an enzyme that's important in signaling pathways. So there's a common theme. There are many aspects of this disease that we can try to interfere in. One of them is signaling pathways, intracellular signaling pathways. This is one aspect, and this was actually, so Rajit Rampal, who spoke today, is the senior lead on this study, evaluating this drug by Sumitomo in patients who have failed a JAK inhibitor. So that's another theme you'll see. If you have failed a JAK inhibitor, and we saw some slides in a previous talk, Unfortunately, the outcomes are not very great in that situation. That is an unmet need. So that is often where we introduce new drugs, particularly monotherapies. And I should have mentioned, in the other two JAK2 inhibitors, you would have had to have failed a prior JAK inhibitor. So before we can introduce drugs earlier on in the disease, we need to make sure that we can do something with them in patients that don't have viable approved options. So this is the same concept. TP-3654 in patients who have relapsed or refractory disease after a prior JAK inhibitor. Notice I have two circles here, actually. I didn't realize that. So greater than 25,000 platelets. I pointed that out for a point. Most trials discriminate. We discriminate against patients who have cytopenias, low blood counts, because most of the drugs we give reduce blood counts, and we can't effectively give them. That's a problem. We recognize that. That's what makes this drug interesting and why I highlighted it here. So in this study of this drug, and I'm showing you some of the data in the expansion phase of the study. So they've actually evaluated a number of patients with this drug very successfully. And here I'm showing you some spleen volume reduction. So the columns going down represent individual patients who got this drug at its recommended phase 2 dose in the phase 1 study. That's 720 milligrams twice a daily. And you can see I circled it. Those are the patients that were at least less than 20 or greater than 25% reduction in their spleen volume. So they had failed a JAK inhibitor, and this drug was, as a single agent without any other JAK inhibition, was reducing spleens in these patients. So suggesting that it had some activity from that angle. But then also the symptom burden improvement was quite impressive. So if you look at where I circled there, those columns, again, are those patients who had a greater than 50% reduction in their symptom burden. That's a very significant reduction in how burdensome and how unwell patients feel. And then if you look on the right, even if you look at individual symptoms, what you can see is it wasn't one symptom that was driving that improvement. In each type of symptom, this drug improved that symptom burden. Patients felt better. And then here is a really important slide. And again, look at where I circled. There was preservation of hematopoiesis, which means the blood counts didn't really dip. So they were able to give this drug at a whopping dose of 720 milligrams twice daily, and that hemoglobin on the left and the platelet count on the right remained stable. We didn't get significant myelosuppression, suggesting that this drug can be given successfully even in patients who have low blood counts, without the fear of making them worse, and that becomes important. It also teases the idea that this could be a great combination drug, because if it doesn't drop counts, you could easily combine it with a JAK inhibitor or other drugs in which you do expect some degree of myelosuppression or lowering of blood counts. Now I'm going to talk about a drug called Reparexin. So this is a research consortium study. So just to give you a sense, the research consortium is a PO1 grant. That's an NIH grant. It's a grant that affords a group of investigators, laboratory and clinical, across multiple centers to come together to use their resources and their talents to translate science into clinical care, directly into clinical care. This is a little bit of a different paradigm I would put out there than the usual drug company driven investigation, which has a motive. So here it's really science leads the way. Marina Kremenskaya, who was on the last talk, and Ruben Mesa joined me as Project 4 leads to help run the consortium of clinical investigators across about 12 centers in the US and Canada. At one point, it was 43 centers around the world. And this is an example of where we took insights from the lab indicating and implicating that IL-8, interleukin-8, one of the important cytokines that is derived from the clone, the abnormal clone of blood cells, and perpetuates the disease, and has been shown to be an adverse prognostic marker by Dr. Teferi and others, would be a great target if we could selectively take it out like a sniper. So JAK inhibitors broadly reduce inflammation, and actually, interestingly, not necessarily IL-8, but this drug just is very clean. It just turns off IL-8 signaling by blocking its ligation, its connection to its receptor on the surface. So we're running a phase 2 study of this drug, which is a drug that's owned by an Italian company called Dompe through our consortium. And it's being evaluated in a lot of different inflammatory diseases. It doesn't have an approval at this point. But in modeling, again, in mice published by Andy Dunbar, Ross Levine, Ron Hoffman, and others, this was a very effective way of treating mice that are engineered to have myelofibrosis, which never perfectly recapitulate humans. But they give us that additional comfort or confidence to take this into a clinical trial. So this is an ongoing clinical trial with a very selective, I don't have any data to show you, very selective approach of targeting a cytokine that we think is a main driver of the disease. Now, This is sensitive. Now, INCA 33989. So this is the antibody that's been highly anticipated. So from Dr. Nagalia's work, 2013, identifying this mutation, understanding then subsequent to that the functioning of this protein, which actually does a lot of different things. We now know that this protein is aberrantly expressed on the surface of the cell in conjunction with the thrombopoietin receptor, the receptor that's important for signaling into the cell through JAK-STAT signaling. And what this antibody does, which was developed by a fabulous scientist in the lab at Insight, is it binds only to the mutant CALR protein. So it's a selective antibody. It's actually it's one of the most simplest therapies I've come across actually in this field, because it doesn't engage the immune system. It doesn't interfere with a signaling pathway specifically, but what it does is it binds the mutant CALR, which is complex to this receptor, and internalizes that whole complex. And in doing so, it turns off the oncogenic signaling pathway. Oncogenic meaning the signaling pathway that we all believe primarily drives this disease, and that's the JAK-STAT signaling pathway. And if you look at what happens in vivo, in cultures, it kills these cells very selectively. It leaves normal cells that don't have mutant CALR alone, and it only takes out the mutant ones. And in mice, it looks very effective. So this, I don't have a red circle there, actually. So this, I went through these slides very carefully. I'm kind of surprised. So this therapy, I think, is probably, from a mutant CALR perspective, is probably one of the most exciting therapies. It took us a while to get here, from the original work that was done in the lab to understand the mutation's role, to understanding the protein, and then understanding how to target it. But this really ushers in a whole new era of targeted therapies. I showed you targeted therapies for JAK2 V617F. Now I'm showing you targeted therapies for mutant CALR. So I do think that we're on the horizon of moving away from broad therapies where we just kind of give everyone a therapy and hope that at least a third of the patients respond, and then if they don't, we'll go on to a different drug, to more personalized approaches to treatment that are informed by mutations. So JAK2 initially, and now CALR. I think we're going to have some data that we will be able to share with you guys, the greater group, by this summertime. That will give us a sense of what we're looking at, because there's 2 studies that are ongoing. There's about 100 patients that are treated, and we're going to start to see whether this drug is safe and whether it really starts to accomplish the goals that have been set out. So the last part of this is where the field has ultimately moved to. This is JAK inhibitor-based combinations. I'm going to talk about Manifest-2, that's pelabresib, Sentry, that's selinexor, and Poesis, that's navtemadlin. So the first one is the Manifest-2 study. This was a study that I think was one of the more important studies from combination standpoint. This was taking a drug called pelabresib. This is a BET inhibitor. This is an epigenetic therapy. So this is, in essence, this is a type of therapy that affects expression of gene sets that are implicated in the pathobiology of the disease. And there's beautiful data preclinically that shows that it works in these cells in culture, and then synergizes and works even better in the presence of a JAK inhibitor. We did a phase 2 study. It looked very promising. We went on to do a phase 3 study, and that's what I'm showing you here, is the week 48 data from the phase 3 study. This was JAK inhibitor-naive patients. So these were patients who had not even seen a JAK inhibitor before. You can see the theme, combinations earlier on in the disease course, not waiting for patients to fail a JAK inhibitor. Can we do better by taking someone who has not yet received therapy and combining what we think is an active drug with the standard of care? And that's what makes this study, I think, beautiful, is that everyone gets the standard of care. So in this study, you were randomized if you had a JAK inhibitor-naive disease and you had a certain degree of disease burden, you needed treatment, to getting pelabresib plus Jakafi, ruxolitinib, or placebo plus Jakafi, ruxolitinib. So everyone gets standard of care. But it's 1-to-1. Half the patients will get the study drug and half won't. And no one knows who's going to get it because it's double-blinded. So we don't know, the patient doesn't know, the computer knows, and the pharmacist is just dispensing the medication by numbers. And what we saw was that there was a doubling. So what I'm showing you here is week 48. Week 24, we've already gone over a year ago. This is follow-up data. We're going to have week 72 data in the summertime. But what I'm showing you here is that there was clear improvement in spleen reduction. So it was doubling of spleen reduction is still maintained. And if you look on the right, I circled those are Kaplan-Meier curves. So those are showing the probability of maintaining a response over time. The dark blue is the pelabresib plus ruxolitinib. You want to be in the dark blue. You want to be on top. You want to continue to maintain that response over time, whereas the lighter colored curve is just ruxolitinib alone, indicating that at a faster rate, patients were not actually maintaining that spleen response. So we got deeper spleen responses and more durable spleen responses with the combination. And we had less, it's hard to see on the slide, but we had less loss of response. That's essentially what I'm saying, is that you can keep the response longer. We also had very dramatic reductions in symptom score. So there was a difference of about 2 points in the symptom score. So you take these numbers, you add them up, and then you get the mean of the numbers, and you say, between the two arms, what was the difference? It was minus 2.13. And I will tell you, for all those statisticians in the room, that is not statistically significant. And it is because of that unfortunate point that this is not now in the approved drug discussions. This is still in an experimental discussion because it didn't hit statistical significance. Although if you look on the right, what we're showing you is that in each type of symptom, the combination of the two drugs versus Jakafi alone was better in reducing the symptom burden. And the yellow line shows what a normal person would be. You cannot improve symptoms with this disease with any drug better than a normal person. And that is one of the problems that we have in terms of understanding how best to implement some of these endpoints. And this is a whole discussion and talk in itself, is how do we perfect these endpoints and the evaluation of these endpoints. But what we saw here was significant improvement of spleen and then bettering of single-agent Jakafi with the addition of pelabresib and less anemia. That's what I'm showing you here. If you look at the red circle, the dark blue is the mean hemoglobins over time in the arm that got the combination of the drug versus the light blue below it that got single-agent Jakafi. So there was a clear improvement and stability, and that lot and those curves stay separated evenly throughout. So there was less anemia with pelabresib, not worsening anemia, less anemia. In fact, there were some patients who got out of the transfusion suite altogether. Now, we like to look at biomarkers because we look for other evidence that we're affecting the disease. So spleen and symptom, those are clinical markers. And then we look in the bone marrow and we say, well, are we affecting bone marrow fibrosis? Because the name of the disease is myelofibrosis. Can we reduce the fibrosis? And you can see that there's doubling of reduction in bone marrow fibrosis. Again, 41% of patients had a reduction in bone marrow fibrosis of at least one grade in that dark blue pie. So significant reduction in bone marrow fibrosis compared to ruxolitinib alone. And on the right, what I'm showing you are levels of cytokines. And you'll notice IL-8 is there. Levels of cytokines. And those are cytokines that we think are inflammatory cytokines that are elaborated by the disease cells. And if we can reduce them, the more we reduce them. And studies have even correlated the reduction of cytokines with improvements in spleen, for example, and symptoms, that's meaningful and is biomarker evidence of disease modification. Now, what was really impressive about this, because you have to also consider, well, okay, John, you're showing me really improved responses from a spleen symptom perspective, some nice biomarker evidence, but how did patients feel? Were there a lot more toxicity issues? You're combining two drugs together. Now, look at that red thing. So first of all, no, there wasn't. So this is a plot that tries to balance the toxicities across the two arms. And what's really interesting here is that you would expect a lot more toxicities with the combination, that's the blue bars, than with the gray bars on the right. And it's rather even. In fact, there was less anemia with this drug than there was, as I pointed out, with single-agent Jakafi. Now, there was more thrombocytopenia, low platelet count, but that was reversible and was not a major reason for discontinuation because the drug is dosed 2 weeks on, 1 week off. So this was a very, I think, exciting first step. Even if it's not an approved drug today, even if we're still following the patients for survival, I think it's a really important study because it shows us that, A, we're onto something. You combine drugs that are rational, that make sense, that are informed by science in the lab, and then you have to set up the studies and you have to follow the patients so that you can really prove that these drugs are adding true benefit. On the same theme, I'm going to talk about imetelstat. This is the Improve MF study. So this was a phase 1b study that we presented at ASH that combined imetelstat. This is a telomerase inhibitor. This is IV. Every drug I've talked about, well, except for the antibody, is oral. But pelabresib is an oral drug. This is an IV drug. This is a drug that's approved for transfusion-dependent lower-risk myelodysplastic syndromes. Those are cousins of MPNs. They have low blood counts. They have ineffective blood cell development. And this drug was approved recently to improve hemoglobins in those patients. We did a randomized phase study that showed that this drug, as a single agent in patients who failed ruxolitinib, improved survival. In a randomized phase 2 study, the survival in the cohort that got this drug was better than patients who got a low dose of this drug, and better than patients if we matched them to a cohort of patients that looked like them that never got the drug. So it really made us think that this drug was active. So there's a randomized phase 3 study that's ongoing where the primary endpoint is survival, which has never been shown here in our disease type. We're always talking about spleen and symptom. But in that study, we're looking at survival. Here we're saying, well, we've got a drug that's active. It's approved in a related disease. It's got a lot of rationale, which I don't have time to go over, but it basically poisons an enzyme that's really key to survival of stem cells. Particularly malignant stem cells depend on it. So if you can poison this enzyme that stem cells rely on, then they won't be able to divide and live. And that's the principle in its simplest form. That's the principle of this drug. So we added it to patients that were taking ruxolitinib. So look at this, the red circle. So you had to have been on ruxolitinib and not had an optimal response. You had to have been on for at least 12 weeks and still have spleen or symptoms, something that the investigator thought was inadequately addressed by the ruxolitinib, the Jakafi alone. So we added in dose cohorts going up, as you can see, from 4.7 all the way to 9.4. That's the dose that we're using in the phase 3 study as a single agent. But here we're combining it and we're giving it every 4 weeks as an infusion over an hour to patients who are getting a stable dose of Jakafi. And what we saw was there were no DLTs, dose-limiting toxicities. We were able to give it, and there was nothing actually that surprised us. Well, there was one thing that surprised us. If you look at pain in the extremities, 41%. I've given a lot of this drug, and we gave a lot in the phase 3. I never really saw this, but for some strange reason, we saw, and this is why it's important to do studies, we saw patients complaining that they felt achy in their arms and legs after the infusion. Don't know what it means, wasn't a very significant complaint, but that was unusual. Other than that, there was really nothing that was surprising about the drug. And if you look on the right, there were no grade 4 or 5 events. That means there was nothing that really bad happened. And what you'll notice is grade 3 means those things that are kind of significant. Those are treatment emergent adverse events that were significant. And you'll see there was some anemia, neutropenia, things that we see with drugs that particularly that target stem cells. But you'll notice that there's one that's totally missing, thrombocytopenia. There was no grade 3 thrombocytopenia. We did not drop platelet counts in the way that we would have anticipated with this drug. So to me, that's a small point. It's nuanced. It may not be picked up by everyone, but that was important because that told me you can dose this drug in patients with advanced disease on ruxolitinib, even with pretty low platelets, and still give it effectively. Now, it's very early on, so I won't draw too many conclusions here, but you can look at my red circle. If you look at my red circle, you can see where I pointed out, and in purple, that's the highest dose, 9.4 milligrams per kilogram. The columns going down show that there was reductions in symptoms up to week 24. But this is really early and very hard to make sense of in a phase 1 study. And then the spleens, also spleens went down. Again, a sense that at the lower doses, you didn't really see spleens going down. And then when you got to 7.3, and we didn't even have the 9.4 data for this presentation, you start to see, in one case, very significant spleen reduction. So we saw that there was activity there. Now, going back to combination therapy. So and Ruben pointed out this earlier. So there's a tendency to repurpose drugs. If we see drugs work in other fields and there's rationale to use it in myelofibrosis, then sometimes there is a reason to say, well, let's see if this works as well or even better in patients with myelofibrosis. And here's one example: selinexor. Selinexor is a drug that's approved in multiple myeloma. Has nothing to do with myelofibrosis. It's a disease of mature B cells, plasma cells. And we had a lot of data from selinexor in that disease state. We started to understand what it does. It inhibits a shuttling protein complex that's important for keeping certain proteins in the nucleus and and messenger RNAs in the cytoplasm. And by disrupting that shuttling protein, you can shut down a lot of pathways that are, again, relevant to the disease biology, including P53. And that comes up a lot, the P53 pathway, the master regulator of cell fate. So here they took a study, very simple study. They took patients who were JAK inhibitor naive, and they added this drug, selinexor, at a low dose, not the way they were giving it high doses in myeloma, once a week, an oral pill once a week to Jakafi. And what they saw at 60 milligrams, I circled it there, was a 78% spleen response rate. That's very high. Again, this is an early phase study. This is not, tons of patients, but a very strong signal early on that this might be an effective therapy. And then we said, well, what about the toxicities? Because we knew that there was toxicities with this drug, GI toxicities. So in our field, the toxicities that tend to plague us are cytopenias, low blood counts, and then gastrointestinal toxicities. Those tend to be the two big ones. So there is toxicity associated with this drug. It's nausea, vomiting, and diarrhea, and it's 100% if you don't prophylax patients. So the key that we learned here was if you give it a low dose and you give it with a JAK inhibitor and you give an antiemetic, an anti-nausea medication with this, you significantly reduce it to 67%, and that's almost exclusively grade 1 nausea. So once a week, much more manageable nausea than if we're not very aggressive with the prophylaxis. And again, biomarker evidence. Here's a graph that shows, again, the columns going down are telling us that we're reducing the amount of mutant VAF, variant allele fraction, CALR, MIPL, JAK2, and another CALR patient, all below 50%. So reducing that amount of mutation in the blood cells of patients that we're measuring is suggesting that we're reducing the burden of disease. If you think about it as a tumor, if we were to collect all of the myelofibrosis cells in your body and put them together as a mass, that would be a tumor. And that's what a lot of people sort of can understand. A mass in the breast, a mass that goes to the lymph node that can spread, that would be metastatic. But the problem with MF is it's a very vague and diffuse disease that's all over the bone marrow, and there is no tumor. It's a blood cancer that's already dispersed. So how do you measure it? Well, this is one way of measuring it, an indirect measurement. So when we see the VAFs go down, we are hopeful that we're actually reducing the amount of disease cells, which would translate to less complications and better outcome. Of course, that's incumbent upon us to prove that in studies, but that's the philosophy and that's the thought process. So that has led to a randomized phase 3 study that's ongoing called the Sentry study. That's taking JAK inhibitor naive patients. You get the standard of care, Jakafi, either plus placebo once a week or selinexor once a week. Again, very much like Manifest-2, trying to see, can we move these therapies up front and get much deeper responses in our patients? Okay, lastly, so this was a study I think really is important. So this is not that the other ones weren't, they're all important, but this was a study that was important because this was really mature data, the Boreas study. This is of a drug called navtemadlin. Marina mentioned idesanotlin. Idesanotlin and navtemadlin are MDM2 inhibitors. So they bind a protein that negatively regulates p53. It's like a double negative. So essentially what happens is you turn on a pathway that is critical, it's programmed in us to induce apoptosis, cell suicide, or senescence, quiet the cell down. And this mechanism that should turn off your MF cells is not working correctly for a multitude of reasons. And one reason we think is because there's negative regulation by the cancer cells to keep this tumor suppressor pathway suppressed. And what we're trying to do is turn it back on. So this drug is given 7 days on, 3 weeks off, and it is an oral drug called navtemadlin. And the Boreas study was a randomized phase 3 study in patients who had failed Jakafi. So they're randomized either to get this drug, navtemadlin, or best available therapy, which was up to the investigator, but excluded a JAK inhibitor. So everyone failed a JAK inhibitor. You couldn't get a JAK inhibitor if you were on the BAT arm, but in a 2-to-1 fashion, you would get navtemadlin. And there was no blinding here. Everyone knew what you were getting. So again, I'm showing you some toxicity. As I said before, GI toxicity can be an issue, so I'm circling it there. It was there, but it was mostly low grade, and it was manageable if you stayed on top of the patients with antiemetics. I'm showing you on the right preservation of hematopoiesis. We didn't get significant myelosuppression, so we could dose it without significant cumulative myelosuppression. And then here, I'm showing you second line, 15% versus 5%. So threefold improvement in spleen reduction. All those columns going down are telling us that those patients had spleen reduction by imaging. This isn't by palpation. This is objective. By imaging with navtemadlin versus BAT, versus best available therapy. And then if you look at symptoms, there was doubling of the symptom score, 24% versus 12%. So very significant reductions in symptoms, as you can see in some of these patients. And then also, I circled it, greater reductions, 21% versus 12% in terms of reductions in the driver mutation levels themselves. And on the right, 45% versus 21% reduction in bone marrow fibrosis. Biomarker evidence of disease modification with navtemadlin. So this has led to a now ongoing study called the POESIS study, which is a study that I think is truly innovative. And I think as a patient, you'll appreciate this. I think most patients really appreciate this study design. It's different. It's saying we're going to take everyone, JAK inhibitor naive. We're not going to put everyone on combination up front because maybe not everyone needs combination up front. So we're going to give you Jakafi, and we're going to watch you for, let's say, 18 weeks. And then we're going to assess your response. If your response is appropriate, if you have a 35% spleen response and a 50% reduction in your symptom score, what's considered an optimal response with Jakafi, you're out. You just stay on the Jakafi. You've done well with that drug. You don't need to get an add-on drug. If you have no response at all, you're refractory, then you should go on to a different type of therapy that's asking a different question. Can you salvage patients who are primarily refractory to Jakafi? What this study is doing is saying we're going to take everyone in between. We're going to take those suboptimal responders, those that have had some response but not adequate to really be true responders or true winners with this drug, Jakafi, and we're going to add either navtemadlin or placebo. We're going to randomize them at that point, and then we're going to demonstrate that we can convert suboptimal responders to responders. So the beauty of this study is that it doesn't necessitate that everyone gets combination therapy, only the people who need it. So in summary, I think new drugs in MF is better options for our patients. Not all of these drugs that I've talked about will get approved. 10% of drugs that we talk about actually make it to the finish line. Despite that, we believe in all of these drugs, but the reality is that they don't all get there. I think we have really exciting new options for JAK inhibition, as I hopefully portrayed to you. So these are, in one case, JAK2 selective. So the type 2 inhibitor is naive to whether it's agnostic to whether it's JAK2 mutant or not. But the JAK2 V617 selective is just for those patients who are JAK2 mutated. But no worry, we have a mutant CALR antibody that for the CALR mutant patients. We have reparexin, nuvisertib. These are drugs that affect different pathways, signaling pathways and cytokine pathways that we think are important. And then JAK inhibitor-based combinations. So we are definitely moving into the era of doublets, maybe even at some point triplet therapies. Really, if you look at most of oncology does not do what we do. It doesn't give one drug, you fail, we give another drug, you fail. It really exploits the different activities of different drugs, combines them in a rational, intelligent manner, and then tries to get very deep responses to get better outcomes. And then I've shown this cartoon here because this was a cartoon we used in our grant for our PO1, again, demonstrating the complexity in which we understand it today that this disease behaves in. So it's really a complex interaction between the myelofibrosis stem cell, that initial cell that picked up the initial mutations and is now aberrant and behaving poorly, and then cells in the stroma, in the area in which it resides, and a complex interplay of signaling molecules, cytokines, and other features that require combinations of therapy to really get deeper responses. And of course, I've circled the most important part here, which is me on this slide, which you can email me. I'm happy to take any questions or answer anything if I don't get it today. And I really appreciate the invitation, appreciate this patient conference, and thank you.